All right, I see we have quite a few attendees, so let's go ahead and get started. Good evening, everyone. Welcome and thank you for attending our Ahead of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Tanya Behel, and I'm a project manager for the Cancer Institute. There are a few housekeeping items that we want to review before we start. During the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants are not able to speak during the conference, but again, we encourage feedback via the chat option. Tonight, we are excited to welcome Dr. Lisa Ercolano, who will be speaking about osteosarcoma variants. Dr. Lisa Ercolano received her medical degree from the University of California Davis School of Medicine in Sacramento, California, graduating with honors. She completed her surgical internship and residency at the University of Pittsburgh Medical Center, Department of Orthopaedics, where she served as administrative chief resident. She received her fellowship training in orthopedic oncology at the Harvard Combined Massachusetts General Hospital. Dr. Ercolano has received numerous academic and clinical awards and honors. She is a published author of medical articles and abstracts on a wide variety of orthopedic topics. She has been involved in various clinical research projects and has presented to medical audiences both locally and nationally. She holds professional memberships with the Pennsylvania Orthopedic Society, the National Honor Society in Psychology, and the Ruth Jackson Orthopedic Society. She is also a candidate member of MSTS and AAOS. Dr. Ercolano was named one of Pittsburgh Magazine's best doctors in 2020. Dr. Ercolano joins the physicians of Allegheny Orthopedic Associates at the Human Motion Center. She has staffing privileges at Allegheny General Hospital and is accepting new patients of all ages. Welcome, Dr. Ercolano.
Thank you very much, Tanya. I appreciate the introduction, and I'm very happy to join the lecture series tonight and talk about the one of the diseases that we take care of here within orthopedic or musculoskeletal oncology. I'd like to talk about osteosarcoma tonight and touch on the variants that actually exist within that disease. There are actually multiple forms of osteosarcoma, and it's very important, obviously, for us to be able to know what we're dealing with when taking care of a patient with one of these diseases, so that it's properly taken care of and that we have the best possible outcomes for folks. So I'd like to focus on that, but before doing so, just quickly to point out, no disclosures, of course. But before we kind of talk specifically about osteosarcoma and the variants that exist within that, I wanted to just kind of back up a little bit and discuss where osteosarcoma falls within this group of diseases. As I often explain both in our resident teaching and when educating patients and families, sarcoma is a term that is often new to people. It is not a common cancer. It is not a common term. It's not something that we necessarily hear a lot about in day-to-day life, versus other types of cancers, which unfortunately, due to their prevalence, most folks are more aware of. So it can be hard to kind of understand what we're talking about when you don't have that frame of reference. So to just sort of start off, sarcoma is a term that comes from Greek for fleshy growth. That's kind of where the name originated from. And it is a cancer. It is a malignancy that is developed from the tissue that makes up our musculoskeletal system. So all the things, all the tissue, all the parts of our arms and legs and the skeleton and the surrounding tissue that moves and motors us, that's the material that we're sort of talking about as the potential tissue that can turn into a sarcoma. So it is very rare. This is a rare, or you'll sometimes hear the term orphaned disease because of that rarity. In adults, it is about 1% of the cancer diagnoses a year, nationally and even internationally. If we include, or rather, if we look specifically at pediatric cancers, it is actually a higher percentage. So obviously, pediatric cancer is a rare entity, thankfully. But of the cancers that occur in the pediatric population, sarcomas can actually be up to about 20% of them. So it's a bigger piece of that group in that age group. In adults, it's only about 1%. So other points to just mention, therefore, these can occur in all age groups, from the quite young to the quite old and everyone in between. It can occur throughout the body, in pretty much all locations. Again, the extremities as well as the pelvis, the spine, and even some of the connective tissue that occurs in the body, the sort of mid portion of the body where we think more about the organs. Almost exclusively, these occur for no currently known reason. And what I mean by that is that we know, for example, that smoking can cause lung cancer. We know that there are some syndromes or some genetic syndromes that patients and or families can have that put them at higher risk for different types of cancers. Far and away with sarcoma, we have not identified any of those causes. They seem to be, for the most part, random mutations that occur that cause these tumors to develop. There are a few scenarios and situations where people do have increased propensity for developing a sarcoma. Listed here is an entity called neurofibromatosis. That is a syndrome with a lot of sort of cousin entities as well, where folks have a higher risk for sarcoma. Multiple hereditary exostosis is another, where folks can have multiple benign bone tumors, and so their risk of one of those tumors developing into a malignancy is higher than the general population. These tumors, again, they arise in the connective tissues of the body, and I think the best way to think about that is we're not talking necessarily about the organs like the lung, the heart, the kidney, the liver. We're talking about the tissues that kind of connect all of those things and that, again, that move our extremities. We broadly divide them into two categories: bone sarcomas and soft tissue sarcomas, which is an important way to start to kind of subdivide these. So a bone sarcoma, and osteosarcoma being an example of that, are cancers that arise from the bone. And then the soft tissue sarcomas are those that arise from all the tissue around the bone. And of all of those, there are many, many subtypes. We're actually learning more and more of these subtypes. So as our ability to look into these tumors, both at the kind of higher levels and then down to the cellular and genetic levels, we're as the years go by, we're able to sort of parse out more types of sarcomas. And hopefully the goal is that in learning the different types, we learn their different behaviors, and that should hopefully have an impact, obviously, on treatment options for them. So just to put in perspective again that the rarity of this disease, the nationwide incidence, these numbers are from a couple of years ago, but they're not, it's not something that's changed significantly. Soft tissue sarcomas in the nation, newly diagnosed per year, about 12,000. Bone sarcomas, which are the even rarer of the two, are about 3,000 per year. If you compare that to the numbers that we unfortunately see with things like breast and prostate cancer or lung cancer, it is far, far, far less common. While it's a good thing that this is not a common disease, the challenge of a rare disease is that these small numbers make it very hard to learn more, to study, to do robust clinical studies, to be able to look at one singular sarcoma subtype with enough volume that we're able to draw conclusions that help in the research and development of treatment. So that is definitely one of the challenges within sarcoma. And I would just say that I think the community in general, what's called the Musculoskeletal Tumor Society, which is sort of one of the main medical societies that takes care of these diseases, have really begun in the last several years, but really started to do a lot more collaborative research, of which AHN has, taken part in a number of these projects, because at any one single institution, the numbers are just so small that it's hard to learn these new things. It's hard to develop new treatments when we just don't have the volume. So participating in these nationwide, oftentimes worldwide or international collaborations is really critical to our learning. Soft tissue sarcomas, to just give a little general information, more so that we can sort of put this in space and then compare to osteosarcoma when we talk a little bit more about that. These are particularly challenging because they tend to be painless. They enlarge, but if they're located deeper in the extremity, maybe in the deep muscle, they can go undetected for quite some time. They're often incidentally noted because they don't necessarily cause pain or difficulty with doing regular everyday activities. Nor do they typically have a lot of other symptoms associated with them. Folks don't really feel ill. They don't have symptoms of fatigue or malaise or any of these other kind of broad symptoms. And so soft tissue sarcomas can actually really sort of evade notice for quite some time. The pie chart here just sort of shows where they occur. A little bit, the highest number of these are seen in the lower extremity, followed by the upper extremity. We do see these still in the body cavity, in and around, but not part of the organ so much, and then also sometimes in the head and neck region. So now, as a comparison to look at the bone sarcomas, on the left side, you just see a list of the different types of bone sarcomas. This isn't completely exhaustive. There are some other types, but these are, by far what we see most commonly. And when I say that, of course, just to reiterate, it's not a common disease, but when we talk about these are the ones that we typically see. We're going to obviously focus on osteosarcoma, but I just wanted to kind of put these into a grouping that makes sense. Now, as opposed to the soft tissue sarcomas, bone sarcomas, they do provide symptoms that alert patients and families and the physicians. So these are typically, as they grow in the bone, they're going to create pain. They can create swelling, weakness. It can be hard to do the normal things that a person, typically does. Range of motion in and around a joint may be limited, difficulty walking, and sometimes they can create and present with a fracture. We always hope to be able to identify and begin treatment before that happens, but when a cancer weakens the bone, it is quite possible sometimes for that bone to fracture under the normal kind of everyday activity that it should be able to withstand well. So now, to really kind of get down and focus on the specific type of sarcoma that we wanted to focus on tonight, and that's osteosarcoma, or otherwise called osteogenic sarcoma. This is the most common primary bone sarcoma, meaning the most common cancer that arises from the bone and that is not a different disease that has traveled to the bone. And that's an important distinction. There are certainly scenarios where our patients develop cancer of a different origin, breast cancer, lung cancer, for example. And if that cancer travels or metastasizes, the skeleton can be a somewhat common location. And so that cancer has traveled to the bone and can create problems there that we, of course, we want to do our best to take care of, to prevent pain, prevent fracture, etc. But that is not a cancer arising from the bone. That is a sarcoma when it arises or starts in the bone. So we're talking specifically about that entity. We see osteosarcomas we see it throughout all age groups, but there is definitely a bimodal distribution where it's most likely. That includes the pediatric population. So the folks, young kids, unfortunately, up to, the age into the 20s. And then that incidence sort of falls off through the ensuing decades until we see another sort of bump in incidence of the disease more into the 60s and 70s. The most common locations that we see osteosarcomas are around the knee, so at the bottom parts of the femur bone and the top parts of the tibia bone or the shin bone here. And the other, pardon me, before I move on, also around the shoulder and the top part of the humerus. And then we also see it in the pelvis bone at times. The metaphysis refers to where in the bone it typically happens. And so the most common place is what's called the metaphysis, which is sort of the flared part of the bone. So again, it's kind of down by the joint, not right at the joint surface where the two bones meet, but kind of where that flare happens. So those are the most common locations. And so certainly if we see a lesion that is occurring in that location and it has other features that support it, our antennas are certainly up in those circumstances. One of the very important things about osteosarcoma is that it does not have one single genetic mutation or error that we've been able to identify. What you see here is a list of things that we've associated with osteosarcoma, meaning folks who have mutations in these specific genes or who have these syndromes. As I mentioned before, there are some that are associated with higher risk of sarcoma. So these are some that are associated with higher risk of osteosarcoma in general, but there's no one single mutation that we've been able to identify in osteosarcoma. It typically actually has it can have varied genetic profile from one to the other, which has, contributes to the difficulty in developing treatments for it when it's not one thing that we can always identify. So when we talk about the term osteosarcoma, if that term is used in conversation, if we are referring to an osteosarcoma, what that implies is sort of what I've listed here as the definition. And that's a high-grade intraosseous, which means originating inside the bone, malignancy or a cancer, in which those malignant cells produce osteoid, which is bone material. So we have a malignancy starting within the bone that is sort of haphazardly producing bone that is not useful for us and is harmful. This is not healthy bone. So what that kind of translates to is the conventional high-grade osteoblastic osteosarcoma. Conventional meaning the most common type that we see. Grade is a very important feature to understand. The grade is something that the pathologist tells us. When the pathologist is evaluating a sample, looking at the cells under the microscope, he or she is telling us how atypical these cells are, how active they look, how aggressive they look. He or she puts that grade on a spectrum between low grade, high grade, and then in the middle, of course, being an intermediate grade. A higher grade type of osteosarcoma implies that those cells are trying to turn over, grow, change, spread more aggressively than a low grade type of cancer. And if there's one thing to sort of remember as we go through the different types and variants of osteosarcoma, truly the most important thing is actually that grade, because the name of the different types they can all have a different grade among them. And that's what we often center a lot of our decisions on, more than the subtype, is how active, what is the grade of that osteosarcoma. The osteoblastic part of that terminology, again, means that it is making bone. On the X-ray, we can see that it is making bone that is abnormal, that does not belong there. So this is just an example of a conventional osteosarcoma. The picture in the middle, this X-ray in the middle of this humerus or upper arm bone, this is a normal humerus here. So the elbow is here, the shoulder is up here, and you can kind of see the ribs off on the inside here. So this is the humerus bone, and that's the normal appearance of a humerus. Here on the left and on the right, so flanking the normal X-ray, are two views of a very abnormal humerus X-ray. So this is the humerus bone, of course, here, and this bright white with sort of this shadowy, fluffy material, and it's, you know, it's no longer kind of a homogeneous white look. It's sort of interspersed with this darker area and this sort of bright white, cloudy, and speckled look to it. Here on the right side of the screen, you just see it from a different view. It's very disordered. This is a tumor that is destructive to the bone, that's starting in the bone, and is creating all of this extra unhealthy bone that is truly that is the cancer. So when we see that, what is it that what steps do we next take? When we suspect an osteosarcoma, or if we have a suspicion, frankly, of just an aggressive bone tumor that is causing harm, we obviously need to take the next steps in order to know what we're working with, know what the diagnosis is, so that we can institute the right treatment. So that evaluation is going to include X-rays of the entire bone to be sure that we have a full picture. An MRI and a CT scan of that bone are also very necessary and useful, because these scans show detail in different ways. And it's really the combination of all of that that allows us to know the extent of what the tumor is doing. Ultimately, the only way to confirm a diagnosis on any of these diseases is with a sampling or with a biopsy, where we have a piece of that tissue that can be evaluated and tested by the pathologist so that we can get the right diagnosis. And that's critical. It is a very difficult stage of the process. There's a lot of very understandable anxiety and frustration with that time period where, you know, we're waiting on the test results. But it is truly critical to get it right, because the treatment varies among these different variants. And so therefore we need to know that we're doing the right thing for that disease. We can obtain those samples either through a needle biopsy, with our radiologist doing that most of the time under usually a CT guided procedure. We ourselves and you know, across the literature, those are very those are sort of our first step. They're very successful procedures. 85–90+% of the time, a needle biopsy is going to give us a diagnosis. And it is done in an outpatient procedure. It is minimally invasive. It is typically, you know, well tolerated for the patient, and a comfortable way to do that. Of course, there are unfortunately times when we don't get a diagnosis with the needle biopsy, if there is not enough informative material, or you know, there's just some question with not enough volume of tissue obtained from the needle. That's when we certainly consider what's called an open biopsy, and that's when we do it's a surgery where we do an incision, and through that method we're able to take a larger volume of that tissue for the pathologist to run the tests. Once that diagnosis is confirmed that we indeed have a type of osteosarcoma, we then move on to what's called staging. And staging determines where else could the tumor be? We now know the diagnosis. We know what's happening in this example in the top of this humerus bone, but we now need to make sure that we know that this tumor has remained localized at that primary site, or has it traveled or metastasized. We stage an osteosarcoma with the use of a CT scan of the chest and a bone scan, because the places that it has a propensity to travel are to the lungs and to other parts of the skeleton. This is a very, very important piece of the puzzle. The prognosis very much so hinges on that staging. So again, the grade that we talked about previously is very important to kind of tell us how active is this tumor in this bone. And then the stage tells us if that tumor has managed to spread in any way yet. The prognosis when we identify an osteosarcoma before there has been spread of that disease elsewhere, we in general, and of course there's some variability, but to sort of be able to kind of place numbers to give as reference, we are able to cure that disease in that patient approximately 70% of the time. What you notice here is that prognosis, if the presentation at the time of diagnosis includes metastatic disease, so it has already spread at that point, unfortunately, that cure rate drops off significantly. And that's where the entire community and research community, is really focusing efforts these days to try to be able to improve that number in particular. So once we've identified all of this information, obviously we want to institute our treatments as soon as possible. And the treatment for osteosarcoma, even having not metastasized, so even with localized only disease at presentation, is a combination of chemotherapy and surgery. Now, again, when I talk about this, I'm talking about the conventional types of osteosarcoma, and then we'll touch on the variants. So chemotherapy we consider as a whole body treatment. It's treating head to toe, and it's treating any cellular disease that we can't see with our eyeballs, that we can't pick up on scans. The surgery is more of a focal treatment. So that's where we are obviously focusing on the primary tumor, or where there's any other tumors that have developed, to remove those from the body. The treatment with chemotherapy was essentially kind of developed, and we learned about the benefit of this many years ago, back into the 1970s. And these drugs that are listed here are sort of the tried and true that have persisted since that time. The typical schedule for the treatment is to start with chemotherapy, and patients will typically get about 10 weeks, 2 to 3 cycles of chemotherapy, after which they receive surgery, and then more chemotherapy after they've healed from their surgery. What we've learned years ago is that if we treated patients with just surgery, even when they did not have evidence of metastatic disease, most of those patients, if we removed the tumors successfully, most of those patients still went on to develop metastatic disease within even 6 months or so. And so what we learned from that is that even when the tumor is localized, and even when all of the scans are negative, there is probably something we refer to as micrometastases, or basically cellular disease that is, for lack of a better word, trying to spread. And so the chemotherapy is able to kill those cells before they can form tumors elsewhere in the body. And so that's what we learned. We instituted the chemotherapy, and our cure rates, drastically improved. And that's kind of what's persisted since. So after that initial chemotherapy, we move into our preparation for surgery. This is to show on these two pictures are MRI sequences of the top of the proximal humerus osteosarcoma. MRI gives certainly more detail on where the tumor extends, its relationship to important anatomy like nerves and blood vessels, and really kind of gives the detail that then allows us as the surgeons to plan what needs to be resected. In general, we talk about a wide excision for a sarcoma, meaning we're not just going to take the tumor out, we're going to take the tumor plus a rim of normal tissue. So this kind of cartoon on the right side shows if the cancer is developing here, we don't want to cut just right around the tumor because we know that there's cells that we can't see that are, that are going to try to persist if we do that. If we have a rim of normal tissue around that tumor, we're more likely to capture all of it and therefore decrease the risk of recurrence in that location. Historically, many sarcomas were treated with amputation. With the development of new technologies, we are able to do what's called limb salvage surgery, where we do a wide excision and reconstruct what was cut out almost all of the time. It is oncologically and technically feasible, 90+% of the time now. So this next picture has some intraoperative photos, which hopefully just are able to kind of show what we're talking about here. So here again is the osteosarcoma at the top of the humerus bone, correlating with that MRI from previous. This is an intraoperative picture showing the nerves and the blood vessels that have been dissected away from the tumor. This is the socket of the shoulder joint, and the top of the humerus bone has been resected with a layer of muscle around it, protecting, covering the tumor so that we're getting that wide margin circumferentially. The tumor then goes to the pathology lab where they process it and section it so that they can evaluate and test it. And so this is a long axis kind of cross section of the tumor in the pathology lab. And so you can see, the top of the humerus bone here, the ball, this is the bottom part. These are normal, edges of the bone. And then this is all of the osteosarcoma that sort of started right in the bone and extended out, really destroying the bone along the way, the normal architecture of the bone there. The far right picture is a postoperative x-ray. Of course, after we remove that top part of the humerus bone, we have different means of reconstructing or recreating the top of the humerus and the joint. In this case, this was reconstructed with what we call a proximal humerus megaprosthetic reconstruction. So this is a metal and partially plastic reconstruction that's recreated the shoulder joint and the top part of the humerus bone. So now kind of in our course, we've done our 10 weeks of chemotherapy. On this left side, these are all the things that have really just improved over the last couple of decades in terms of our imaging is so much more precise, our ability to biopsy in different manners to get a diagnosis, and then the ways that we can do surgery, both the resection and the reconstruction have improved markedly. That specimen, when it goes to the pathologist, they evaluate it as I talked about a minute ago, and they're going to tell us the margin status. So we're looking for negative margins, and we're looking for another feature, which is what's called percent necrosis. So essentially the pathologist is evaluating that tumor and telling us how much of that tumor is still alive or viable. And what we want to see is that most of that tumor is dead. And that implies that the chemotherapy was effective and has killed most of that tumor. When we see that, that is a good prognostic indicator. When it is not a high amount of necrosis, that's when there are challenges in terms of what the right next steps are. What we've unfortunately not been able to do is figure out exactly what the next right drugs are to use if we think that the typical chemotherapy agents were not as effective. This is not an absolute, but it is a marker that we look at and we use. These are two of the types of systemic therapy drugs that are very much in play in trials and that we're learning about these days and that we think and hope are going to hold promise for this scenario going forward. So now just to kind of talk about the different variants of osteosarcoma. So again, what's bolded here in the darker black are what we've talked about so far, the conventional intramedullary osteoblastic. These are the multiple other types of osteosarcomas that can exist. And some of those can vary very much so from what the typical X-ray looks like. And so it's therefore very important to understand that these exist so that we know to look out for them, because they may not on the surface be as obvious. The types that are in purple here are simply to point out that these we actually treat a little bit differently than that typical pattern that we just went through. And so therefore, again, very important to know what we're dealing with so we treat it properly. A few examples just to point out, these are relatively recent cases that we've had where, again, these did not fit the perfect typical presentation for osteosarcoma. And so we had to be sure of our diagnosis so that we could treat this properly. This is an osteosarcoma that is not grossly making bone. It's not producing that bone that's so obvious on the X-ray. It's also in what we call the diaphysis, or the mid part of the bone, rather than down by the joint. This was an osteoblastoma like osteosarcoma. An osteoblastoma is a benign type of bone tumor, and there are osteosarcomas like this one that can mimic that benign disease. Here, we were able to get the diagnosis, treat that patient, and here you can see that the mid portion of the bone's been resected and reconstructed. This is a very interesting patient who we met a couple years back at the age of 21. She had at that time a lesion here in her tibia that actually has very benign features. Very much so looks like an entity that we see not terribly uncommonly called an NOF, but unfortunately, it was not present when she was a few years younger, which doesn't fit the natural history of that entity. And so we looked further into it. Small lesion, not causing bone, but a little bit of evidence that this is trying to grow. And this turned out to be what's called a giant cell rich osteosarcoma. This is another subtype that does not as apparently make that bone that is so easy to identify on a typical X-ray. The benefit of having found this when it was quite small is that we were able to do a resection, a wide resection, whereby we did not have to take the joint surface away, which often is the case for osteosarcomas because they occur near the joints. So you just sort of see the lesion here. We were able to customize a plan for that patient with a company whereby we use our imaging and very specific software to plan out what part of the bone needs to be resected. There's 3D printing technology that allows us to create cutting guides for the operating room that are specific to this patient's anatomy, as well as find and source and create cutting guides that are custom for an allograft, a cadaver bone that will fit the exact defect that is created after the resection. And so these are just models showing that. These are photos showing the guide affixed to the bone. The bone has been cut. The bone housing the tumor has been cut out here. This is the allograft being cut to fit the defect, which is then affixed with a plate. So on the in the path lab, this is then processed, and you see this is the bone cut out, and this is the sarcoma that is growing within it that we've done our wide resection of. Here is the post-op x-rays here showing that the allograft has fit that defect. The plate holds that in place so that this can all heal and recreate the defect that we had to resect. This is a similar case, what's called a par osteosarcoma. So this one varies from the conventional in that it doesn't develop from within the middle of the bone. It actually develops on the surface of the bone. And so this can be, this can mimic other types of benign tumors that more commonly happen in that location. And this tumor, quite importantly, also tends to be a low-grade tumor. The difference here is that we treat this with the same surgical principles, but those low-grade are osteosarcomas actually do not benefit from chemotherapy, and therefore we don't need to use those treatments for those patients. This case was done quite similarly, actually, with the 3D printed custom cutting guides. I apologize, I don't have those pictures, but this is the postoperative X-ray showing that the bone has been resected that housed that sarcoma growing off of the surface of it, and an allograft has been put in its place. This is a radiolucent plate and screws to affix all that in place and allow that to go on to heal. We also see more commonly in that second mode, the bimodal age group, the more the older patients that we typically see with sarcomas, osteosarcomas, are often ones that develop from an underlying chronic process. So not necessarily a genetic mutation that we know of, as I said before, but if they have a chronic long-standing disease, like a Paget's disease of bone, or other examples might be prior locations of radiation. So folks who received radiation very appropriately for a disease or a different cancer in their history, that does increase the risk of a secondary sarcoma or osteosarcoma of that bone if it was treated. And so here you see the underlying kind of permeative look of this bone is consistent with a Paget's disease, which is just a metabolic disease of bone. It is not a cancer or any sort of tumor condition. But unfortunately, there's a small percentage, a rare likelihood, where that can, over years and years of that disease being present, can secondarily transform, and you start to see this abnormal bone being formed, which even in not 6 months or so can really sort of act quite aggressively and grow significantly. So I know kind of the sort of a quick race through some of those things. There's a lot of nuance and subtlety to those. Certainly my goal was to try to just introduce that, place that into a framework where sarcoma and osteosarcoma kind of makes sense, and the different variants and the steps that we take in diagnosing and treating. I think one of the biggest challenges with sarcomas is education, because it is so rare and so unknown. And I think because of the rarity of it, it is not something that we routinely screen for because it is so rare. So I think we talk with our patients and their families. It's so important to be your own advocate. You should have information, you should be informed, you should ask questions and get the answers that you deserve. I think, we always want to be very sensitive to the fact that a person knows their body and how things feel more better than anyone. And so if you're feeling something that's abnormal, we need to check it out. And it's important that obviously you're expecting the best out of everyone taking care of you. And it's truly a team effort in all of these diseases, in sarcoma and osteosarcoma in general. So it's important to have all the right team members that can deal with the cancer, the side effects of the treatment, the rehabilitation that's necessary after going through these types of procedures and treatments. So that's a lot more of a talk that we could give, but it's really important, especially for these rare diseases. So with that, I will thank you for having me, and I'm more than happy to answer any questions.
Thank you, Dr. Ercolano, for that amazing overview of sarcoma and osteosarcoma. We do have one question in the Q&A, and we'd encourage anybody else that has a question or a concern to share with Dr. Ercolano, please do so. So the first question is, how long does it take to grow to the point where a patient has symptoms like pain and swelling?
Yeah, fantastic question. So the short answer is that it's really hard to answer that question. But what we do know is that the bone has to be compromised by probably about 25 to 30% before it gives us those clues. So that's a challenge because that's a fair amount of growth that can occur before it comes to notice. And part of that reason is because our bone is actually very dynamic. It is very responsive, and it has a lot of kind of redundancy built into it. It has a lot of ability to, if something is happening to our bone that our bone doesn't like, it reacts to it. It tries to sort of wall it off. It tries to heal itself, so to speak. And so those things can be going on, leaving the person sort of unaware until it gets to a point where it's painful. But sort of the technical answer is that the bone again has to be kind of compromised, probably at least 25% before there's going to be symptoms. I think what we try to talk to our patients about is to be certainly aware of what they're feeling, and if something doesn't respond to rest, to kind of the conservative things that we do, like anti-inflammatory medicine, rest, physical therapy, things just don't feel right, like they're improving. By no means does that mean you have a sarcoma, but it means you should listen to your body and be checked out.
Thank you. And just a comment, Dr. Ercolano, thank you for the great presentation. Any other questions or information that you would like to hear from Dr. Ercolano this evening? Okay. Well, go ahead.
Sorry, I would just say there is a fantastic nonprofit that AHN is involved with, as well as other UPMC, West Virginia University. It's sort of a kind of regional nonprofit called Pittsburgh Cure Sarcoma. I just would encourage anyone who has interest in being involved, or you're a patient or a family member. It's a fantastic group where it's patients, it's family members. Our physicians and other care teams are involved too. There are fundraisers, there are educational events. We've been very successful at raising money that's going to local research. AHN has been we've received grants from PCS that's funding some of our research. So anyone with a particular connection to sarcoma that's interested, I'd encourage you just to look into that. It's a good way to be involved, to learn, to be kind of in a community that knows of this rare thing, and has common experiences with people.
Sounds great. Thank you, Dr. Ercolano.
Sure.
I'll go ahead and share my screen. Okay, I hope everyone can see that. All right. Thank you, everyone, for attending our Ahead of Cancer lecture this evening. Please continue to join us at our monthly Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded. If you are interested in rewatching tonight's lecture, check back on the AHN YouTube channel, www.youtube.com/Allegheny Health Network, for the full recording in about a week. This video, as well as all other past lectures, will be posted under the Ahead of Cancer playlist. If you would like to schedule an appointment or have questions regarding a potential cancer concern, please call the Hope line at 412-578-4673 to schedule an appointment. You may also call our 24-hour Nurse for You line at 412-687-4968. Thank you, Dr. Ercolano, for the wonderful presentation, and thanks to all who attended the lecture this evening.
Thank you.